Sure, we're going to start off with hepatitis. So it's viral, obviously, so no antibiotic can treat it. One of the biggest treatments is rest. A lot of malice, a lot of fatigue is one of the biggest signs of hepatitis and any kind of liver disorders, as stated in the prior lecture. But that's such a mild disorder, isn't it? It's such a mild complaint sometimes. And also GI disorders. So really pay attention to that because we think maybe it's GERD. We think maybe we ate something bad. So just food for thought. Okay, viral, systemic viral infection causes necrosis, inflammation, and liver. So A and E, broke this down real quickly and easy for you here, are by fecal oral routes. So dirty hands, not washing in between going to the bathroom. This is caused a lot by food handling, people not washing their hands properly or not washing their hands at all. A is kind of that one that you catch on the food, the cruise ships. Such close quarters, not proper hygiene of toilet areas, not washing your hands properly. It's just handling of food in a dirty way. B and C is bloodborne. This could be blood products, dialysis, dirty needles, by sexual intercourse. D, only people with hepatitis B can get it. Hepatitis G is a globin issue. We're not going to worry about that one. Non-viral hepatitis is caused by toxic and drug-induced. So this could be polypharmacy, lack of education on how to take medications properly. One of the biggest, most common ones, too, I can think of is new parents not understanding the workings of medication. When a child has a cold, Tylenol and ibuprofen don't take it away. It treats the symptoms of aches and fever. They take it around the clock. They give too much. They don't understand weights. They don't understand kilograms. That's why changes in labels of age and when to give it, the potency of it. Another big one is adults that become injured or have been dealing with pain for a while. Maybe they've been taking Tylenol around the clock for a toothache or, some kind of headache, and go to the ER, get a procedure done, and now they're taking Vicodin or Percocet for this issue. They don't realize the acetaminophen's in there as well, and they continue to take the Tylenol on top of it, and there's your issue. That could be very hepatotoxic. Not understanding how to take your prescribed medications. Could be too much or forgot, not paying attention. Polypharmacy, again, no collaborative effort with doctors. Seeing 3 doctors and 3 different prescriptions and how and when and who for these medications can cause hepatotoxicity as well in this hepatitis. Okay, hepatitis A, again, spread of poor hand hygiene, fecal oral incubation. So each one of these slides is going to decipher the difference in all of them. How I would study is separating those differences and separating what's the same. And then you understand the differences in between. That's what you kind of look at and memorize. 2 to 6 weeks for incubation. So illness may last 4 to 8 weeks. So this is a long-term thing. It's going to be a collaborative effort with healthcare providers. Here's the age range. Flu-like symptoms, low-grade fever, anorexia. It's always kind of a nutrition issue. Remember, latent signs is jaundice. Jaundice usually is more of a latent sign, but this is more of the prominent sign to see something's wrong. It's just not needing to rest. Dark urine, indigestion, epigastric distress, and now an enlarged liver and spleen. So maybe review how to assess if a liver is enlarged, where to palpate. Management, okay? So just prevention is key here. So that, proper hand hygiene, how to wash your hands again appropriately under those nails, keeping those nails clean, proper sewage disposal. A high population with hepatitis A is the homeless population. And this hepatitis A population is increasing immensely in Arizona and across the nation because our homeless population has increased immensely with everything going on. Why in this population? Because they lack access to clean water. They lack access to just simple hygiene of a shower, brushing their teeth, clean clothes, things like that we take for granted. Proper toilet, proper sewage, proper disposing of their waste. Let's see. Prison systems is another one with the lack of hygiene, the close quarters, things like that. The lack of soap, simple things. So prevention is the biggest thing here in education. Vaccine. Everybody should have access to this vaccination, and that doesn't seem to be the case. So immunoglobulin for contact, a passive immunity, bad rest during acute stage. Again, rest is the only true, the more you rest, the quicker you'll get better in the majority of these cases. And I want you to start thinking of how long this said it takes, how long you have it, how long it takes to heal and rest. So now let's think of the adult that has to work, a single parent. They can't miss a day of work. They can't pay their bills. They don't make enough. 3 jobs. Our lives are stressful. Go, go, go. I understand with COVID it's changed a bit, but same concept. America is constantly in a rat race, right? And it's hard to rest. You're going to have lack of childcare, somebody to take care of your children, money, cost, bills. So this is going to be a collaborative effort with outside community resources, for financial support, food banks, many different things. So it's our job to identify these factors of issues of being able to treat their hepatitis A, bringing in case management and community collaborations, and nutritional support. Okay, depending on, liver enzymes and everything, is protein the best? Sodium probably isn't. All right, B. So here is considered to be blood, saliva, semen. So anyway, we would be at risk for being close to these, sexually transmitted from infant to birth. This is different. Worldwide cause of cirrhosis and liver cancer. This one rears its ugly head, and it's a long one, and it's a hard road to get rid of it. Risk factors. Go through the risk factors. Remember, it's risky behaviors such as promiscuity is a big one here. Different sexual partners, multiple sexual partners, secret sexual behaviors, needles, not being honest with the type of sexual partners you have, blood transfusions, dialysis, things like that. It has a longer incubation of 1 to 6 months. Manifestations, insidious and variable, same as Hep A, so there you go. Put those there. Loss of appetite, dyspepsia, abdominal pain, same. Jaundice may or may not occur for hepatitis B. But remember, if you see the trend, and we've been talking about jaundice even since the last lecture, jaundice is a prominent sign that it's a little later that something's wrong. Okay, so management. For this one, remember it's a virus. We don't have antibiotics. But this one, we're going to give some interferons and possibly some antivirals. We're not going to start them. We are going to try rest. We're going to do least invasive, and then possibly, if this isn't working, to start them on some antivirals. Antivirals, understand the pharmacokinetics, pay attention, see the names. Antivirals in itself are very harsh medications. They have their own severe side effects. They cause more malaise, more fatigue. There's a lot that goes to them, so it needs to be a consideration, not just given. Bed rest, nutritional support, vaccine for people at high risk, those healthcare providers, right? This is that immunization that we're always being tested to see if we are immune or not. Passive immunization for those exposed, share precautions, infectious control, screening, blood products. What else can we do to prevent this? Those everyday, now prior to COVID world, we just need to not skip steps and just take those environmental protocols. Always glove when touching a patient. Always glove when entering their room. Something as simple as skipping corners, and you walk in just to talk to the patient and they need to be repositioned in bed or moved and things like that. You go to turn them and there's something sharp in the bed. They're bleeding. It gets on you. You didn't realize you had a paper cut of some kind. Simple things like that can prevent those things from happening. You see the incubation periods. You see how they... if you're touching things in the room, basic things like that of keeping yourself safe with proper PPE is best. Screening blood and blood products. All right, hepatitis C is chronic. That doesn't mean they're always symptomatic. It just means that it's chronic. It's always there. They always test positive. They have their flare-ups with proper care, proper management of anything. Okay, we can have an optimal life. Okay, transmitted by blood, sexual contact, including needles, sticks, and sharing. So pretty much kind of the same as B. Most common in bloodborne infections. So a little bit more in that area. A cause of 1/3 cases of liver cancer. So inevitably, possibly, if this person has a chronic hep C that is not always controlled, they could be more at risk for this. So it's inevitable, it kind of seems. All right, risk factors on that table. Please pay attention. It's more detailed. Here's the incubation period for hep C. Symptoms are usually mild. Okay? Chronic carrier state frequently occurs. So You could go months without any symptoms and actually be positive for this, and that's what's interesting. All right, so management. So what's the difference here? Antiviral medications are given here. Okay, they are given here. It's a part of treatment. No alcohol. If this is going to be your new normal, alcohol is going to just worsen it and intensify the symptoms. Medications that affect liver should be avoided. So any kind of hepatic medications. I go back to, again, especially if a patient is on numerous amounts of medication, the doctors, the providers have to all collaboratively come together. Is this the right medication for this patient now? Can this amount be decreased? What are the ramifications of taking them off this certain medication? In some cases, it's not going to be okay. We're going to have to decrease the amount. In others, we have to. So it's quite a juggling act. All right, prevention. Public health programs, clean needle exchanges, making sure people who have some kind of issue with needles or using needles with addiction has access to this to prevent, the spread of Hep C. Community resources such as providing condoms, education on safe sex, of oral, of other kinds. There's still a large population out there that doesn't understand any kind of sexual act can translate this, meaning oral, anal. Just having those safety mechanisms there, community education, and safety needles for healthcare workers. There's still facilities. We have that one cap flip here, one hand away from you. There's still facilities that don't have that. It's still, you got to recap, and we can rush and still hurt ourselves. There's still those risks. Okay, D. Only person that can get it is Hep B. Blood and sexual transmission, IV use injection, likely develops in the filament of liver failure and chronic, so incubation period. So just understand that's how it's acquired for D. Okay, E. Usually when I've lectured in the past, it's always been, this is more of a third world country problem. They don't have truly any access to clean water. They have to sterilize the water. It wasn't sterilized properly. Poor hygiene. Poor areas, very dirty areas. It's not separate from where they're using the restroom, things like that in a third world area. Unfortunately, with the disparities in America that we are now seeing, the homeless population increasing, hepatitis E is becoming more prevalent in America, and that's very sad. So understand that it resembles A, self-limiting prevention, good hygiene, and hand washing. These simplistic things should be available to every human being, and it's actually becoming an issue more, and that's disheartening. Okay. So non-viral, so toxic and drug-induced. So either one, toxic can be, it's come from chemotherapies, certain exposures some patients have been through, procedures, environments of work. Drug-induced hepatitis, again, can be accidental, polypharmacy. I spoke of the child with acetaminophen, the adult, and it could just be by accident, or it can be induced. We've seen this also with possibly potentials of committing suicide, overdose medication. No, they did not take enough to end their life, but they took enough to really affect their liver. So pay attention to that and understand the difference. So that's what drug-induced hepatitis is. It's caused by some other issue. Could be alcohol as well. Okay? All right, so hepatic cirrhosis. All right, cirrhosis. So I kind of described it a little bit in the last lecture. When the liver starts, so a healthy liver is red and meaty and it's porous and it just looks like a fresh slab of meat. It's, healthy and bright red, and I don't know about bright red, but when you start seeing cirrhosis, it looks like a scar. It looks like it's calloused in those areas, and where it's calloused, there's nothing filtering through and moving through. That's where the pressure starts to build and the weight starts to build. So it kind of looks like patches of old, nasty scars all over. So I'm just trying to get you to paint that picture. Please pay attention to the pathway. I can't stress that enough for pancreas and liver. You got to understand the functions. Okay, so liver enlargement. These are everything we went through in the last lecture. Obstruction, ascites. infection, mental deterioration. Remember that hepatic encephalopathy, varices, edema, those vitamin deficiencies such as B is a big one, thiamine. You'll see patients that have liver issues are going to get heavy doses of IV thiamine. You'll start seeing the nails go ugly and crack, and you'll just start seeing unhealthy nails, unhealthy skin. That pruritus, remember the hair will fall out with these lack of vitamins. So these are subtle pieces of the puzzle that we need to put together to catch these things. Okay. Here is your basic priority of care that you normally see. These are going to be those interventions that we got to do: promoting rest, nutritional status, skin care, reduce moving skin. Where in here do you see medications? You don't. That is not our scope of practice. Administering, monitoring, making sure the medication is appropriate for them, side effects, do they need it at this time? But medicine is not our scope of practice. I see a lot of interventions provided by you guys stating, give the meds. Okay, we need to give the meds, but that is the doctor. That is the doctor's role. There are so many things we can do while we're waiting for those medication orders, or we're waiting to get that IV in. Not every intervention. This is the nursing practice right here. Okay, there's a lot of things we can do to keep them safe. We talked about bleeding last lecture, all that risk for bleeding, decluttering the room, risk for falls, staying with the patient, reorienting them as respectful as possible. Okay? All right, so rest. So decreasing the stimuli in the room, decreasing the lighting, understanding their stamina, the shortness of breath, especially when they have ascites, sitting them up if that's the case, that anxiety that possibly they're having, that edema, that swelling. If bleeding is an issue and a risk factor, oxygen, supplemental oxygen, because lack of volume, lack of perfusion, mild exercises and rest. We're always talking about surgical patients up, moving. These patients still need to move, don't get me wrong. We still need proper perfusion, but we need to take into consideration their malice, their possible extreme swelling, their ascites. So it has to be measurable goals for every patient. You can't memorize this. You guys keep trying to memorize things. When you walk into a room, every patient's different. We want to gauge how our patient's feeling today. If they're really not feeling it and they're having large ascites, possibly while waiting to call the doctor and explaining their discomfort today, we'll have them sit in the chair, possibly. Encourage those small, frequent meals. Maybe some exercises in the bed, dangling at the side of the bed, maybe walking with some oxygen, moving around with some oxygen, maybe just to the door today, some activity, but it has to measure your patient's needs. Nutritional status, low sodium, protein, depending on the severity of what is going on with their liver. It's going to depend on where they're at. Measures to prevent hazardous immobility. All right, status, so strict I's and O's. Remember, increased accumulation of ammonia, ascites. We have fluid and electrolyte imbalance, inadequate distribution of our fluid, possibly some of that albumin to pull in the fluid where it needs to be. I can't stress enough, constantly monitoring those vitals. Strict I's and O's, daily weights. If our patient is going for a synthesis, let's pay attention to that weight before and after. Small frequent meals, high calorie, no sodium. Again, diet is very hard to get in here. They have a lot of anorexia they suffer with, so maybe small portions. Little interventions you'll see in the charts, keeping the food warm, prolonged, offering to heat the food. Nobody wants a cold meal, so telling them, we're going to bring in 5 small meals instead. Little things like that make the biggest difference for a patient. That's in our role. Okay, let's see. Supplementing those vitamins I talked about. Now remember, depending on the severity of the liver function, we don't tolerate fat soluble. We can't process those fats. We can't pass, so that can cause steatorrhea. Okay, so we want to make sure the medications they're getting, they can absorb properly. So that's food for thought there. Okay, other interventions, skin care as stated prior, keeping those nails short so they can't scratch themselves crazy. Frequent repositioning, keeping their skin properly moisturized to prevent that itching. Risk for injury, again, they are at high risk for bleeding regardless of any issue here, if any liver disorders. So decluttering the area, skidded socks, fall alert, keeping the call light near. All right. Again, this is a huge collaborative effort to prevent these complications. We went through these complications and understanding that each one of these is life-threatening and possibly can be prevented. All of these are preventable with catching things early, proper prevention, proper monitoring. All right? That bleeding hemorrhage, remember that lack of volume can lead to shock and death. Remember hepatic encephalopathy. We got to get that ammonia out of that body system. They're going to be confused, delirious, possibly lead to seizures and death. Lactulose is a big one here, to medication to decrease that, and knowing the subtle signs of this, knowing that it's not okay for your patient to ever be confused, and that volume excess, understanding that your patient is seeming a little more short of breath, a little more panic, you're starting to heal more moisture in the lungs, excess swelling from this morning. The frequent assessments you should be doing every time you go into your patient's room will catch these things. Now, the basics of concept of cancer you got in 105, I just want to kind of go across liver cancer with you here real quick. Majority of the time, it's manifested from hepatitis is what you need to understand. Frequent alcohol use, drug abuse, these hepatitis, this is what leads to cancer if these things are not controlled. Remember the chronic hepatitis, such as, B, if it wasn't controlled, C is chronic, can lead to such a tragic diagnosis. So understand signs and symptoms. They manifest the same way that any kind of GI disorder does, as you can see here. So diagnosis of this is not easy. That's what you need to take away from this here. Here's management. It goes from least invasive to invasive. Understanding that it is considered very invasive usually when diagnosed, so a lot of this can be just palliative and prolonged for a few years. Okay, here's the surgical management for it. Moving on, I want to talk a little bit about liver transplant, though. I just want to stress, everything has occurred that gets to here. The sad part about this is the ethical portion and dilemma, and that's what you really need to focus on. The table's right there. Let's see, how can I put this? Not everybody is a candidate for a liver transplant, and that's where the ethical portion comes in. It could be something as simple as, somebody has done some prominent damage to their liver over the years, acquired hep C, but has turned their life around and been sober for probably the last 10 years. I'm just being dramatic about it, but and now it's come to, the damage they have done has now really caused their liver to failure, and their only risk of survival, their only hope for survival is a transplant. Does this person get on the list or not? Do they relapse? Should we give it to somebody at risk for relapsing with an addiction issue versus somebody who has possibly suffered from NASH, which is non-alcoholic, has had a healthy lifestyle, and it was just kind of a luck of the draw, or, had some kind of reaction to drugs that caused liver failure? Who are we to make those decisions? And these are the ethical dilemmas that come into a liver transplant. Another thing, and I'm being very broad with my numbers in my statement, but the basic facts of this is the success rate of a liver transplant is far fewer than other transplants. There's not a good success rate when it comes to liver transplant. It could prolong maybe a few years, maybe not really quality of life with rejection, but it can prolong life for a few years. You guys may know somebody who's been successful. There are success stories out there, but this is not truly one of the most successful ones. I have a patient, I don't know much about her, but this is kind of that ethical portion you see in healthcare. It was a young 32-year-old woman. I just happened to be on shift that day. I don't know her history. I wasn't taking care of her. I just happened to be covering. The doctor went in to give a prognosis of her liver is failing. She has probably 30 days, 2 small children, and a husband. It was a very traumatic prognosis for her. She wasn't a candidate. I'm not sure why. I don't know if it was from past behavior, past history, or the disease, but your heart goes out to a young woman who's about to leave their whole family on this earth at such a young age. So who's making the decision that she can't be on that list? She won't make it. She only has 30 days. She won't even make it to a transplant. Maybe that's why, because she was so far gone. But do you see those ethical portions that come into play? So this is where I want you to kind of pay attention. Here's just kind of how it works. Just understand it's very intense. It's not always successful. It affects the whole GI system. High risk for rejection. Okay. Our role here is a lot of education, a lot of anti-rejection, a lot of follow-up and emphasis. A lot of this comes into play too if the patient has a reputation for not following up, for taking care of it. They want somebody who's going to do everything they can to make sure they're not rejecting their liver, that they're doing the steps, they're doing the diet, they're doing the healthy lifestyle to preserve this liver. All right, that is it for your lecture.